see in terms of normal endometrial glands to stroma ratio. All right, now what do we call it when we have endometrial glands that go down into the myometrium, the muscle layer? What we call it, adeno means glands, meiosis means muscle. The endometrial benign glands have decided to take up shop in your muscle layer. So this is benign glands in the myometrium. So basically what's happening here is the basal layer of endometrium just starts growing down. It starts growing down into the muscle layer. So we're gonna see benign appearing endometrial glands. Now this is very important because does endometrial adenocarcinomas invade the muscle? Yeah, they do too, but they're gonna be atypical, malignant cells. So very important to listen to the description. Benign appearing endometrial glands and stroma within the myometrium, that's adenomyosis. Now, since it's composed of stratum basalis, these glands don't typically have cyclic bleeding. They don't bleed every month. It's more basalis. But they will give you a thick uterine wall. So look at the thickness of this wall. It's kind of, they describe it as a globular, thickened uterus. It's like a big globular mass. And if you notice, you kind of see like trabeculations here, kind of like trabeculations. That's kind of the buzzword for thick, hypertrophied muscle. With all these glands in between, the muscle gets thicker. So you tend to see this globular uterus with thickened, trabeculated wall. Whenever I say the word trabeculated, that means muscular, thick muscle bundles, thick hypertrophy. That's all hypertrophy. Now tell me, if the wall is this thick, it's going to mess things up. So she's going to get irregular periods, like heavy periods. She can have dysmenorrhea, pain, because every month, this doesn't bleed much, but it might bleed a little bit, and that's going to, bleeding in the wall is going to hurt. So pain during the cycle. And she can also have pelvic pain right before the cycle too, because these glands may enlarge, and it'll stretch the wall and hurt. So again, adenomyosis, not a big deal, but you better recognize it. It could be a cause of regular heavy bleeding. All right, now, what's it called if the endometrial glands are outside the uterus? If they're in the wall, adenomyosis. What if they're outside, in a different organ? That's called endometriosis. This is a 5-star one. They love this one. Endometriosis is the presence of normal endometrial glands and stroma, but they're in the wrong spot. They're outside the uterus. So how do they get out of the uterus? How do they get out? 3 theories. First theory is regurgitant flow. When a woman has menses, the endometrial glands and stroma shut off and they come out the vagina. That's the menstrual form. Well, in some women, they may get some regurgitation, some retrograde flow. So now these glands get carried through the fallopian tube into the pelvic cavity. So this is called the regurgitant flow theory, and it's probably correct. Because if this theory is correct, what should be the most common site because the fallopian tube empties right out onto it? The ovary. And that's the most common site for endometriosis. Endometrial glands in the ovary. So this regurgitant theory may be right because it goes through the fallopian tube right onto the ovary. Now it also deposits on the ligaments, on the fallopian tube, in this pouch back here. What's this pouch behind the uterus in front of the rectum? We call it the retrouterine pouch of Douglas. That's the lowest portion of the female pelvis. So whenever this fluid, it's always going to go down there. So when that fluid is going to go down there and it's going to start growing in that retrouterine pouch. It can also grow on the anywhere on the pelvis. So it can grow on the bowel, it can grow on the omentum, and grow here in the omentum. Now, the second theory is metaplasia. The coelomic lining, that's what lines the peritoneal cavity. Coelomic lining can turn to anything. Coelomic epithelium can undergo metaplasia. So some people think it's just an area that underwent metaplasia and turned to endometrial glands. That's how you have to, it's just metaplasia. Okay, that's an interesting theory. Now, one more theory. How the heck could it get to my brain? I've seen endometriosis in the brain. Well, in that case, the endometrial glands probably got into your blood vessels. They probably spread via lymphatics or arteries and veins, and then they grew, they went to the lymph node, they started growing, they went to the brain, they started growing. So that could explain that. Now, if there's three theories, what does it mean? It means we don't know. And if there's three theories, it usually means probably more than one is right. So for some women, it might be regurgitative flow. For some women, it might be metaplasia. For other women, it might be getting in the blood vessels and spreading that way. So it's probably more than one, probably, because there's no consensus here. But I know this, wherever the endometrial glands are, well, they need to continue to grow. So how are they going to survive when they're outside of the uterus? Well, in that area, they're going to produce a lot of prostaglandin E2, and there's going to be increased production of aromatase. Aromatase will convert androgens to estrogens, and that will allow these glands to survive outside the uterus. So again, wherever they implant, they got to make a lot of prostaglandins and a lot of aromatase to continue to survive. Now, problem. What happens next month to these endometrial glands? They're going to bleed. Every month they're going to bleed. So you're going to get cyclic bleeding. So how's it going to present? Every month, you're going to get severe abdominal pain during your menses. But John, my menstrual cycle is uncomfortable already. Exactly. This often gets missed. Because how do you know if your menstrual cramps are better or worse than the woman next to you? Pain is subjective. We don't know. Sometimes when we diagnose this, we go to the woman and say, weren't your periods really bad? And she goes, yeah, they were horrible. But I thought that's the way it was. They didn't know. See, women are tough. If a man had a mens, it would be all over. We'd be out the whole month. But women suffer in silence. They just keep going. They got to get the job done. Women are clearly superior to the species. Sorry, guys. Every month they get paid, they keep on going. Wow. So yeah, so this is often missed. Often missed. Now, under the microscope, when we biopsy these areas, we're going to see benign endometrial gland, benign stroma, and since it keeps bleeding, we're going to see hemosiderin-laden macrophages because every month it bleeds. Now, what's it going to look like on gross? It's going to look red-brown. So some people say if you put a laparoscope in, you look at it, it looks like a powder burn, like a gunshot. The powder comes out and burns your skin. So whenever I see a close gunshot, I'll see a hole over the berlin, and around the edges I'll see burns, powder burns. That's what it looks like, burns. Because it's the bleeding, the old blood. Hemolyzed blood looks brown. So red brown. Now if it occurs on the ovary, most common site, you'll get a chocolate cyst. All this old blood will make a big old mass. It'll become a chocolate cyst of the ovary. And they give it a fancy term. Isn't this nasty? Here's the ovary. I cut it open. When you cut it open, melted Hershey's chocolate bar comes out. Look at this melted stuff. It looks like a really chocolate. This is called a chocolate cyst of the ovary. Now, to try to trick you, hold on one second. To try to trick you, they may call it an endometrioma. They say it's a tumor. No, it's not a tumor. It's benign endometrial glands in the wrong spot. So they call it endometrioma because it'll make it sound like a tumor. No, it's just benign glands. They're bleeding a lot, so you get this big old cyst filled with blood. Now, what is this chocolate stuff? It ain't chocolate. This is hemolyzed blood. It's old blood. Now tell me, what's the chance you get pregnant when your ovary looks like this? This is a big cause. This counts for about 50% of cases of infertility. Because this is going to be it's going to be in the ovaries and scleroderma, it's going to be in the foramen tube and scleroderma, and the ligaments and scleroderma. It's a major cause of infertility. This and pelvic inflammatory disease, two big causes of infertility. Now, locations, it's often all over the place. But the most common site is the ovary. It often produces a big hemorrhagic chocolate cyst. The uterine ligaments are common, fallopian tubes, the pouch of Douglas, very dependent. If it's on the peritoneal cavity, it looks red-brown, we call it powder burns. When you do a laparoscope, it looks like burns. You can see it in the rectovaginal septum. Well, if it's on the rectum, that's going to give you constipation and maybe some pain during defecation. Now, clinical. This is incredibly common. Somebody you know has it. Very common in reproductive age women. And about 10% of women in the reproductive age will actually present. A lot of women will have it and just suffer with it. 10% will come in with it. And it causes about 50% of infertility. Happened to my brother. He was trying to get pregnant, and they couldn't get pregnant. And they went in, and they found out his wife had endometriosis. And so that was the reason that they were having trouble getting pregnant. So they didn't eat very drug. So what else can it give you? Well, it's going to give you pain during the menses, so lower abdominal discomfort during the menses, pelvic pain. They call this dysmenorrhea, pain during the menses. If it's on the uterine serosum, it can give you pain during intercourse. If it's on the bladder, it can give you pain during urination. If it's on the rectum, it gives you pain on defecation. So it can be all over the place. Now, this is something that's kind of interesting. If I have benign endometrial glands in my ovary, could they become malignant? Yeah. So you can get an endometrial cancer in your ovary. Yep. So ovarian implants of endometriosis may lead to ovarian endometrioid adenocarcinoma. That's interesting. So you can get this turning malignant on you because it's in the wrong spot. So that's pretty rare, but it happens on exams. Okay, because you don't usually see endometrial cancer in an ovary unless there's endometriosis there first. All right, now here's what it looks like. Under the microscope, this is the colon, by the way, the colon. Notice the colonic epithelium has all these crypts. And then notice, in the submucosa underneath this is this nodule here. It looks like these dilated glands, which look different than the colonic glands. Let me go closer. Here are the colonic normal epithelial glands with a lot of goblet cell. Now look at this area here. Do you notice the stroma is very, very purple? That's endometrial stroma. And then these glands are darker. These are endometrial glands. There's no goblet cells here. These are endometrial. So this is endometrial glands and stroma outside the uterus. This is endometriosis. So benign endometrial glands and stroma in an ectopic location. That's so great. I've seen it in the brain. I've seen the lung. I've seen endometriosis in the colon. I've seen it all over the place. It can happen anywhere. But again, benign. All right, now let's talk about a benign tumor of the wall. The myometrium is made of smooth muscle. So if you get a benign smooth muscle tumor of the myometrium, we call it a leiomyoma. Myo is muscle, myoma is benign muscle tumor, lyo is smooth muscle. So this is a benign tumor of the myometrial smooth muscle. It's very common, by the way. In reproductive age women, 30 to 50% of all women have it. And it's most common in African Americans. They tend to have multiple lesions. They have a lot of them. Now, it is a tumor. It's monoclonal. We often see rearrangements of chromosomes 6 and 12, low yield. I just want you to know it's a tumor. It does have mutations. Now, what causes it to grow? Well, the uterus and the myometrium responds to hormones. So estrogen causes it to grow. So when is it going to grow? If you get pregnant. If you get pregnant, it grows. If you're on oral contraceptive, it grows. At menopause, it shrinks down, regresses, becomes a calcified mass. So if you ever look at an x-ray of the abdomen of an old African American woman, you often see multiple calcified small masses. Those are old regressed leiomyomas. They're old fibroids. Some people go as fibroids because a lot of fibrosis. So these are fibroids, leiomyomas. All right, so again, it's all about hormones. Oh, by the way, if you're pregnant and this grows, it's going to push and push on the endometrial cavity and push, and what's going to happen? You know who's the baby. So this is a cause of loss of abortions. It's a cause of loss of babies. Yeah, so always look for this. When you keep having recurrent fetal loss, I keep losing babies, look for leiomyomas because they grow during the pregnancy, they push the baby out, they kill the baby. Now let's talk about what we look at grossly. They're often multiple, and they're often very firm, so we often call them fibroids. Now they're benign, so they're well circumscribed, they're gray white, but here's the key. Thick muscle is trabeculated. So you'll see this twirling, trabeculated appearance on cut surface. Again, when I get trabeculation, thick muscle, either hypertrophy or a tumor. Okay? Now locations are important. If it's submucosal, it's under the endometrium, what's going to push on it? You're going to get vaginal bleeding. You get infertility because you have a big mass pushing on the cavity, you can't get pregnant, and it can cause loss of feti. Now, if it's in the inside the middle of the wall, usually just causes a mass lesion, like a palpable lesion. If it's on the outside, that definitely produces a palpable mass outside the uterus. So it can be in different locations. The one that's very interesting is submucosal because it gives you vaginal bleeding, gives you infertility, and it can push on the baby, lose a baby. On the microscope, we'll see bundles of smooth muscle. We'll see areas of fibrosis, and we'll sometimes see degeneration like calcification and cells breaking down, but it's benign. And of course, there are genetic mutations, low yield. Now let's go to clinical. This is going to present usually with irregular vaginal bleeding. So heavy periods because it's pushing on endometrium. It could present as a palpable mass with like a dragon's sensation. Something's holding me down, you know, it's big old tumors. Rare cases can metastasize. Now this drives me crazy. It's a benign tumor, but I've seen it metastasize. So they call it a benign metastasizing leiomyoma. I'm like, if it metastasizes, shouldn't we call it malignant? I know it's weird, but it's one of the rare times a benign tumor will actually metastasize. One of the rare cases you'll ever see that. And then could it turn malignant? Yeah, rarely it can turn malignant, but I'll be honest. Most malignant leiomyosarcomas, they arise de novo. They usually arise de novo. Okay, so they usually arise on their own, and they usually arise post-menopausally. That's a very important distinguishing feature between a benign leiomyoma and a malignant leiomyosarcoma. Now let's look at a couple pictures. Here's the uterus. I cut it in half, so cut it in half and open. I basically opened it like it's a book. So here is the cervix down here, and the other half is up here. So here's the cervix. Do you see the endocervical canal here? See the endocervical canal? Now, this uterine cavity is supposed to be triangular shaped. Oh, it's kind of squished. It's the endometrial cavity. It was supposed to be triangular. It's kind of squished because of this submucosal leiomyoma. See it? It's pushing in and crushing the cavity. Good luck getting pregnant. It's going to cause infertility. Here's another one. This is not going to cause much problems. Here's another one on the wall. It's this one that's going to cause the problem. So again, they're multiple, well circumscribed. They're white tan. They're kind of hard to see, but they're kind of whirling. It's hard to see at this medication, but they're kind of whirling in thick trabeculation. Benign, benign, benign. Now, under the microscope, we're going to see these spindle-shaped cells. They're kind of elongated, elongated, elongated. And notice these areas of fibrosis. So call them fibroids sometimes, because they're very firm on fibrosis. So elongated spindle cells, I don't see any mitosis, very rare to see any mitosis here, because this is a benign, slow-growing tumor. Okay? Now, I want you to compare it to a leiomyosarcoma. Okay, remember that. They occur postmenopausally. Now, nothing should grow in the uterus after menopause. After menopause, the endometrium should really become atrophic. The myometrium, everything should atrophy. So if the endometrium grows, that's endometrial adenocarcinoma. If the myometrium grows after menopause, it's a leiomyosarcoma. So this is a malignant tumor of the myometrial smooth muscle. It's most common postmenopausally. It's usually single mass postmenopausal. And most cases arise de novo. It can arise from a pre-existing old leiomyoma. Most cases arise as new tumors. Now they're usually solitary, and of course they're malignant. So they're going to be hemorrhagic and necrotic. So tell me, which one of these is benign and which one of these is malignant? Okay, benign leiomyoma, hemorrhagic necrotic thing, that's a leiomyosarcoma. See, this is postmenopausal. These are shrinking. These are getting smaller. They're getting calcified. They're shrinking. This one's growing, bleeding, causing pain. This is a malignant one. See the hemorrhage? It's all bleeding in this thing. This is a necrotic one. All right, now under the microscope, the tumor cells, you're going to see necrosis. You're going to see funny looking cells and lots of mitosis. Lots of mitosis. Now, the better differentiate is, the better you'll do. The more anaplastic, the worse it is. Now, I want you to take a look at this picture. Compared to the last picture, there's a lot more cells, a lot more nuclei here. But notice the mitosis, mitosis, mitosis. So they're kind of a little bit more pleomorphic, more nuclei, more pleomorphic, different shapes. And look at the mitotic activity. That's a big clue to tell you this is malignant. Now the problem is if I don't get it all out, it will recur. You must get this out completely, and sarcomas will spread hematogenous. So always check the lung for sarcomas. They always spread hematogenically to lungs first. So always check the lungs. If it spreads to your lungs, you're going to try to resect that too. Try to save them, because this is a malignant tumor. Okay, it's postmenopausal. All right, now, the last concept is endometrial hyperplasia and endometrial adenocarcinomas. Very high yield, because endometrial adenocarcinoma is a very common tumor of the lower female system. So we need to know this well. Hyperplasia leads to cancer. Now, hyperplasia, it's a precursor of endometrial carcinoma, and the mechanism is too much hormones. Unopposed estrogens. If I have progestins, it sheds. But if I have excess, I have unopposed estrogens, the endometrium gets thicker and thicker and doesn't shed. So you get hyperplasia. So it's all about unopposed estrogens. Now, risk factors. Who has too much estrogen? People that don't ovulate. So I'm going to go from proliferative phase to secretory phase. Then I'm supposed to ovulate and then have shedding. If you don't ovulate, you go back to proliferative, then back to secretory. This is going to get really thick because you never let it shed. So anovulatory cycles gives you dysfunctional uterine bleeding because of hyperplasia. What else? Unopposed estrogens are going to cause hyperplasia. Obesity, more estrogens on board when you're obese. Polycystic ovarian syndrome, they have high estrogen as well. And estrogen-producing tumors of an ovary, like granulosa thecal cell tumors. Granulosa cells make estrogen. So that tumor can lead to endometrial hyperplasia and endometrial adenocarcinoma. Now, under the microscope, remember, we're supposed to see 50% stroma, 50% glands. Should be 50-50. What we're going to see here is a proliferation of the glands relative to the stroma. So increased gland to stroma ratio. So over here, I got a gland, nice stroma, gland. So it looks okay the ratio here, but notice this area. It's a lot of glands and not much stroma. So this is a classic example of simple endometrial hyperplasia. Just too many glands per square foot. Now look at this. That's simple. This is complex. So again, too many glands, but they're not round anymore. They're kind of budding and branching. So this is called complex atypia. Simple, round glands. Budding glands, that's complex. But again, they're both hyperplasia. Simple, complex. Okay, I don't care. What I care about is atypical nuclear features. Because when the nucleus inside doesn't become atypical, you're getting dysplasia, you're going to get cancer. So again, hyperplasia is one thing. Atypical hyperplasia, that's the word you're looking for. You're looking for that word atypical. So take a look at this picture. Again, I see glands that are basically back to back, not much stroma here, but notice the cells are large. They're, compared to these, they're large, they're very juicy looking. This has nuclear and cytotypic atypia. So this would be called complex atypical hyperplasia. I don't care, simple, I don't care, complex, I don't care. Look for that word atypical. When you see atypical, you gotta watch him like a hawk. That's the one that's gonna get cancer. Okay? All right, so let me make sure I didn't miss anything here. Proliferation of glands, right, the stroma is the key. The severity of hyperplasia basically corresponds to how much estrogen and how long you've had high estrogen on board. Now we look at the architecture. Is it just simple round glands, or are they more complex? So it's simple hyperplasia versus complex, too many glands, but are they simple or are they kind of budding? But the key is the presence or absence of atypia. If you see atypia, that's the big risk of cancer. Hyperplasia by itself, no big deal. It's atypical hyperplasia. That's the one we're worried about because it's getting atypical. It's got mutations. Now, which mutation does it usually have? It has inactivating mutation of PTEN. Now, PTEN is a tumor suppressor gene. It's supposed to stop growth. It's a break on the PI3 kinase ATK signaling pathway. It's a break on this growth pathway. So if I lose the break, you're going to grow and grow and grow, get hyperplasia, eventually get cancer. So I want you to know that PTEN mutations are often knocked out in prostate tumors, thyroid tumors, and endometrial hyperplasia and endometrial cancers. Isn't that great when the name tells you everything? So PTEN is on chromosome 10, and it's knocked out in prostate, thyroid, and endometrial tumors. Other tumors have it knocked out as well, but those are the three biggies. I love it when the name tells me the answer. Now let's just take another look at an example here. Notice there's too many glands in this area compared to the stroma. There's way too many glands. They're crowding, but they're still round. They're round, they're becoming a little cystic and dilated. This is called simple hyperplasia. Okay, so we see irregular or cystic dilated glands, just too many of them. Now here is complex. Notice these glands are getting very irregular, they're one after the other, they're kind of budding and branching here, they're sticking to each other. So again, too many glands is hyperplasia, and this looks very complex. They're not simple round. Okay, I don't care. What I care about is that we're atypical. So if I see all these back-to-back glands, but look at the size of the nuclei, they're getting huge, big cells, this is atypia. This is atypical. Go a little closer, now you can really see it. Look at these dark nuclei, they're piling up, you can't even see the cells are piling up on each other. This is nuclear atypia. So this would be a complex atypical hyperplasia. Again, I don't care about the complex, I care about atypia. Atypia. You're not going to be asked to say, is it simple, is it complex? You'll be asked, is it atypical? Yeah, this looks ugly. These aren't simple single cells. These look like they're piling up. These look terrible. This is the risk factor for proceeding to cancer. So let's get to cancer, and then we'll end this chapter. Endometrial cancer is the most common cancer of the lower female system. I'm excluding the breast because breast cancer is the most common female tumor. But if you exclude the breast, the lower system, endometrial carcinoma is the most common. We need to talk about it. Now there's two major forms. The first form looks like the endometrium. So what would you call it? You'd call it endometrioid adenocarcinoma. Another name for its type 1. This accounts for most cases. Makes sense. Endometrial tumor should look like the endometrium. So endometrioid adenocarcinoma is most common. But there's another rarer type. It's only about 50%, but this one's bad. This is called serous, often papillary adenocarcinoma. Serous papillary adenocarcinoma. So we'll talk about that. That's rare, but it's bad. Now let's talk about endometrioid first. It looks like the endometrium because it came from hyperplasia. So this is most common in postmenopausal, but early postmenopause. Early. So usually 55 to 65. Menopause is around, on average, about 52, 53. That's when you get menopause. So this is early postmenopausal. And they're going to come in with postmenopausal bleeding or maybe a leukorrhea, but usually it's postmenopausal bleeding. That's always worrisome. Endometrium should bleed. So we're going to have to do a dilation of the cervix and curettage, or an endometrial biopsy. I got to look at the endometrium. So dilate the cervix and do a curettage or do a endometrial biopsy. Now, this tumor is going to invade. So the key is, how deep is it invading the myometrium? Because the deeper it goes, the more likely it is to find blood vessels. So depth of invasion is the key. Now, it will metastasize to regional lymph nodes and distant as well, but usually does it later in the course. So invades locally, deep, 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 and then eventually it spreads. Now, risk factors are the things that cause hyperplasia. Obesity, because obesity is high estrogen. Diabetes and hypertension, because that's the metabolic syndrome. If you have diabetes and hypertension, you're going to have obesity. So these are only risk factors because they're associated with obesity. That's the metabolic syndrome. Infertility is going to be because you never had a break. You're always cycling. You never had a break. You never had a pregnancy. How about unopposed exogenous estrogens like estrogen replacement therapy, tamoxifen? These are big risk factors. By the way, who's on tamoxifen? Women with breast cancer. Now, it's an anti-estrogen for the breast, but it's a positive estrogen for the endometrium, so it can lead to hyperplasia and endometrial cancer. And of course, all these are risk factors for estrogen, which causes hyperplasia. And remember the word atypical. Atypical hyperplasia is the big risk factor here. So estrogen leads to atypical hyperplasia, which leads to endometrioid adenocarcinoma. Now, in terms of genes, what was the mutation for hyperplasia? PTEN. That's the mutation for this as well. Now, they often have mismatch repair gene mutations as well. Do you remember the mutated phenotype? So they often have PTEN from the hyperplasia. That's going to cause losing the break, you're going to grow. And then they get what's called a mutated phenotype. They lose the mismatch repair genes. Now they accumulate more mutations until they become malignant and invasive. Cool. Now, under the microscope, they look very similar to proliferative endometrium. So how do I know it's a tumor? Well, they're back to back. There's no stroma in between them. So they're atypical nuclei, they're back to back. That's the key feature. Look for the lack of intervening stroma. And then we're going to grade them. Do they look relatively well differentiated? Are they kind of intermediate? Are they the sheets of tumor ugly? That'd be grade 3. So you don't have to grade it. I'm just going to show it for fun. But it's graded from 1 to 3. 3 is the worst. Now, before I show you it, I want to talk about papillary serous adenocarcinoma. It's only 15%, and when I say papillary serous, this tumor is usually found in the ovary. That's what we see this in the ovary. Papillary serous is the most common ovarian malignancy that kills women. It kills the ovarian tumor that kills. Because what does it do? These little papillae structures break off the ovary and they seed your belly. It starts growing everywhere in your belly. So let's repeat, papillary serous carcinoma of the ovary is horrible because it rapidly seeds the belly, it grows everywhere, and it's hard to cure that once it seeds. So papillary serous usually found in the ovary. Now it can be found in the endometrium. It's only about 50%. Now here's the key. It tends to be older than endometrioid. Endometrioid was postmenopausal but early. This is much later. This is 60s, 70s. So it's usually 65 and up. So these are usually old women. More common in African Americans, and it comes from atrophy. They're old. Their endometrium is atrophic. It doesn't come from hyperplasia. It doesn't come from PTEN. It comes from P53 mutations. No, that's a bad one. Exactly. That's why this tumor kills women. It has P53 mutation. So it spreads quickly and it kills quickly. So that's what I want you to remember. P10 for endometrioid, that's what hyperplasia has, that's what endometrioid has. But P53 is for the bad one. Now these are going to form papillary structure. You'll see the tumor cells are in these, thrown up in these tufts or these papillae, and they're very atypical looking. They're almost always grade 3. They look ugly. They're ugly looking cells. Very aggressive tumor. Now, how does it spread? Well, remember, it's in the uterus. So in the uterus, here's my endometrial cavity, and the endometrium is going to be really thin, very trophic, and then I'm going to see this papillary tumor. See the little fingers, little spikes? Well, those little fingers are going to break off and float out the fallopian tube and it's going to seed your belly. Just like the ovarian tumor does, it's gonna seed your belly, you're gonna come in with ascites, and basically a death sentence. Once it seeds, it's terrible. So it spreads via the fallopian tube into the peritoneal cavity and just seeds everywhere. It can also spread in the vaginal lymph nodes too, but it's the seeding that makes it horrible. So remember, it's just like the ovary, but it occurs in the endometrium this time. Now, other types aside from serous, you can also have clear cell carcinoma. Remember, we have that in the vagina. You can also have it in the endometrium. And you can also have a malignant mixed Müllerian tumor. Malignant, but it's mixed. In other words, there's not just carcinoma, there's sarcoma too. So we'll talk about that in a second. So that's another form that we'll talk about. It's a kind of separate form because it's like a mixed tumor. It's got carcinoma and sarcoma together. That's kind of interesting. All right, now I want to show you the sequence here. Two different types of cancer. Endometrioid carcinoma looks like endometrium. Looks like endometrial glands. They're just back to back with no intervening stroma. Now look at this. Atrophic epithelium. Really old woman, very atrophic endometrial island, gets a couple p53 mutations. Oh, now you get ugly cells, they start growing, they throw themselves up into these papillae, these papillary structures. Now you get papilloserous. So papilloserous is about p53. But endometrioid starts as a normal endometrium, then it starts out with p10. So now you get too many glands. This is called hyperplasia, simple. Here's complex. Then it picks up another mutation. Well, let me go this one first. First it gets the mutated phenotype. So it picks up MHL mismatch repair gene mutations. Now I'm a mutated phenotype. Once I pick up another mutation like RAS, well, now I'm going to start turning atypical. The nuclei get bigger and darker, bigger and darker. So remember, hyperplasia with atypia. It's picking up additional mutations. And then it's going to get a couple more mutations, and now the glands are back to back. There's no stroma in between them. Now we have a grade 1, well-differentiated, endometrioid adenocarcinoma. Makes sense? It looks like the endometrium. It's just back to back and very atypical looking. All right, now let me show you a couple of actual pictures. Okay, so different genes for different tumors. Let me show you actual pictures. Now this is kind of hard to see. This is the uterus that's been opened up. Here's the endometrial cavity. Notice it's packed with this big old polypoid mass, another polypoid mass, another polypoid mass, because endometrial tumors grow as big polyps. And then they invade deep into the wall. So they grow up and then they grow down. They invade the wall. So you see these polypoid masses. Anytime you see an endometrial polyp, think about cancer. That's a polypoid cancer. Now, underneath the microscope, I'm seeing glands, endometrial glands. Now, they're elongated, they're back to back. So this is a pretty well differentiated one. Grade 1, and again, I know it's not hyperplasia because there's no intervening stroma. It's just gland next to gland next to gland. There's like no stroma here. So it's not hyperplasia anymore. This is cancer. And the nuclei, if you go closer, they're very ugly. Now, compare that one to this one. This one's making some glands, but here it's kind of solid. I don't see good glands. Maybe, is this a gland? But this is a nice gland. That's a good one. So this one, it's kind of getting less than, this is grade 2. And then look at grade 3. Do you see the glands here? Nope. I just see sheets of tumor. Over here, some glands. That's better differentiated. This right here, that's grade 3. It's just sheets of tumor. Make sense? Now again, I'm never going to ask you to grade them. I'm never going to ask you to grade them. But I want you to see if it looks more like normal, that's lower grade. That's kind of losing its glandular appearance. Intermediate loses most of its glands. It's like sheets now, that's very bad. So again, I want you to heard the term of grading. I don't expect you to be able to grade, unless you know the pathology, then I don't expect you to grade. Otherwise, I just want you to know the terms. Now, what about some of the appearances here? Well, let me take a look at this one. See here, we have this tumor here. Now, it's still intraepithelial. It hasn't invaded yet. But look at the cells. They're discohesive. They're ugly looking. Now, if I'm Stain it with P53. P3, oh, that's serous. That's serous, papillary serous. Now it's starting to make little papillary structures, but not yet. Here's a nice papillary structure. Here's a nice papilla. Oh, this is invasive papillary. This is bad. Look at this. So this was in situ intraepithelium. This is invasive. Nice papillary structures. Again, if I light it up with P3 mutations, notice here's the fibrous cord. Here are the malignant tumor cells lining the papillary structure, and notice they're all positive for P53 mutation. So this is what papillary serous looks like. This one's a bad one. You don't want papillary serous, spreads by seeding. Okay, now here's one more special type of endometrial tumor. We call it malignant, but it's mixed Müllerian tumor. Now another name for it is carcinosarcoma. It's a mixture. It's part endometrial adenocarcinoma, part stromal sarcoma. So basically we're seeing a mixture of endometrial adenocarcinoma. Now which type of endometrial tumor? It could be endometrioid, it could be serous, it could be clear cell, it doesn't matter. Any kind of adenocarcinoma of the endometrium with a malignant stromal mesenchymal component. So take a look here. Do you see the glands? Nice gland, nice gland. So this would be an endometrioid adenocarcinoma. But look in between. See the stroma? Look at these, so many cells, and look how dark that one is. Look how dark. This is a malignant mesenchymal component. Now, this mesenchymal component often looks like stromal sarcoma, or it could look like leiomyosarcoma. It could look like a leiomyosarcoma. It could be elongated like leiomyosarcoma cells. So again, there's a uterine stromal malignant component, and that's the key. You want me to pick this on the exam? Tell me there's carcinoma and sarcoma together, malignant mixed Müllerian tumor. Now remind me, does the uterus have a stroma? Yeah, so it's malignant? Okay. Does a uterus have a leiomyoma? Does it have it's got smooth muscle. But what if the stromal component is rhabdomyosarcoma? You're not supposed to have wrapped striated muscle in your uterus. No. What if it's chondrosarcoma? That's not supposed to be there. So if the mesenchymal component is rhabdomyosarcoma, they call this heterologous components. That's an error that shouldn't be there. That is a worse component. So again, if it's malignant mixed and the stromal component is rhabdomyosarcoma or chondrosarcoma, that is worse. It's better if it's just stromal sarcoma or leiomyosarcoma, because that's what's supposed to be in the uterus. Now, unfortunately, these are very malignant, and they will metastasize to the lymph node. So these purple dots are lymphocytes, and then you see these chunks of tumor here. This is the malignant tumor that is now metastasized to your lymph node. Not good. Not good when these things spread. Okay, one last thing, fallopian tubes. For fallopian tubes, there's only two reasons they get asked. Inflammation, which is salpingitis. Now, usually it's caused by a sexually transmitted disease, which is ascendant. It's a pelvic inflammatory disease, usually gonococcus or chlamydia, one of those two. Gonococcus or chlamydia, most common. Now, sometimes it's mycoplasma, sometimes E. coli, and chronic. If it's ever chronic salpingitis, look for granulomas, look for TB. That one's going to be a chronic form, because TB loves fallopian tubes. Now, when you have chlamydia or gonococcus there, you often get an abscess between the tube and the ovary. We call it a tubo-ovarian abscess. Now, the problem with salpingitis is it's going to heal with scarring. So you're going to scar your fallopian tube, so now you have infertility, and if you do get pregnant, it's going to get stuck in the fibrosis, and you're going to get ectopic tubal pregnancy. And that's a very important risk factor. It's a big risk factor for infertility, pelvic inflammatory disease, and don't forget the other one was endometriosis. And of course, ectopic tubal, the big risk factor is scarring from prior PID. Now, if you notice here, here's the cervix, here's the uterus. It hasn't been opened, but this is the uterus. Nice uterus, has been opened. Here's the fallopian tube here, looks good. Here's the ovary here. Okay, what do you tell me about this? Jeepers, this is like a giant fallopian tube. Yeah, because it's full of pus. They might cut it open, it would pus would pour out. This is a red, swollen edematous. This is like an abscess. Cut it open and you'll see pus. So that's not good. That's like a tubular abscess. All right, now the second thing you need to know about fallopian tubes is they can get adenocarcinomas. They can have adenocarcinoma of a fallopian tube. Now they're often endometrioid or serous. The same types you got in the endometrium, right? So endometrioid or serous. Now serous tumors are often associated with BRCA mutations. BRCA. So remember that was breast and ovarian, also fallopian tube too, fallopian tube. In fact, some cases of their ovarian tumor is going to be a fallopian tumor that falls onto the ovary and grows in the ovary. Yeah, so we found out some cases of ovarian tumor are really fallopian tube tumors that are just growing into the ovary. Just some cases, small number, but especially in the BRCA mutation. BRCA get a lot of fallopian tube tumors and endometrial tumors as well. Now, since it's in the fallopian tube, it can easily break out and seed. So not good. Fallopian tube tumors often seed the abdominal cavity. All right, another chapter is done, or at least another section is done. We still have to do the ovary, which is super high yield, and we need to do some disease of pregnancy too. But first, let me just do a little review here, and then we'll stop the tape and do another tape. Let's just do a little endometrial review. Okay, what is the term for abnormal bleeding of the uterus without structural or organic pathology? I can't find anything, but yet you're having dysfunction. Oh, that's called abnormal or dysfunctional uterine bleeding. Only blame the hormones if you rule out everything else. All right, and it's usually due that way aneuploidy cycles. What's the term for irregular bleeding in between the periods? What we call it metorrhagia. Metorrhagia, bleeding in between, like breakthrough bleeding in between the cycles. Okay, what is it called when you have adhesions? Oh, I forgot to mention this. If you have irregular bleeding, you might want to check the uterus. Let's do a dilation and curettage. Well, what if I let the medical student do it? Well, they're going to scrape and squeeze. If I get to do it, I'm going to scrape and scrape out. I'm going to scrape everything off. So if you do a vigorous dilation and curettage, and you scrape off the mucosa, it's now going to heal with scarring. You just scarred the uterine cavity. You just created adhesions. Now that gets a fancy name. We call this Asherman syndrome. When you do a vigorous DNC and you scrape too much of the mucosa off,
is that a live feed?
And it heals with scarring, well, this is going to lead to infertility. You're scarring the cavity. Yep, Asherman syndrome. And usually occurs when you let a medical student try to do a DNC and you don't watch them close enough. You gotta watch them. Because they're so excited. They're like, I can't believe I'm scraping someone's uterus. Oh my God, this is the coolest thing. And where's my camera? I need something. Yeah, great. Oh, I've been doing it for an hour. Oops. Yeah. So you do nice DNC scraping a few times, but not too much or you get ash. It's kind of rare, by the way. You really have to scrape pretty bad. All right, now what do you call it when you see presence of plasma cells in the endometrium? That's not normal. That is chronic endometritis. Chronic inflammation of the endometrium. Now, I want you to remember IUDs, often associated with IUDs. So what organism is going to have sulfur granules and it grows on IUDs? Actinomyces. So actinomyces is a big cause of chronic endometritis because it grows on IUDs and causes inflammation of the endometrium. All right, now, growth of the basal endometrial layer down into the myometrium. Now, the glands are in the myometrium. That's called adenomyosis, glands in the muscle. And you have a thick uterus, trabeculated. Sometimes you get a little abdominal pain. Sometimes you get a little bleeding as well. That's adenomyosis. All right, now, what is it called when presence of endometrial glands and stroma are outside the uterus, but it's benign? Benign endometrial glands, that's called endometriosis. Now, malignant endometrial glands, so that's a metastatic endometrial adenocarcinoma. So I have to specify benign endometrial glands and stroma outside the uterus, endometriosis. And every month it's going to bleed. What is the appearance of the ovary? when you have endometriosis? Well, often it's involved and it bleeds. You get a lot of blood, whole blood, looks like chocolate. They call it a chocolate cyst of the ovary, also known as an endometrioma, but it's not a tumor. It's benign endometrial glands and stroma and a lot of blood in the ovary. That's all it is. Now, it could be a source of a cancer later on. This could always turn to cancer. You get endometrioid cancers from these little rests in the ovary. Okay, multiple myometrial masses with a world trabecular cut cervix. Well, that's leiomyomas. They're benign, usually during reproductive life when you have a lot of hormones. Postmenopausal, they shrink. They go away, they calcify. All right, now what do you call it when you have a single postmenopausal myometrial mass that's growing postmenopausally? Leiomyosarcoma. Look for leiomytosis. Look for necrosis and hemorrhage. Single mass growing postmenopausally, muscle layer. Okay, increased numbers of endometrial glands with crowding and budding glands. Okay, if they're crowding, that's called hyperplasia. If there's budding, that's complex. So we're going to call this complex endometrial hyperplasia. But what was the key word I always look for? I look for the word atypia. So what is the most important feature to look for when I say hyperplasia? When you see my report, look for that word atypical hyperplasia. I don't care if simple atypical hyperplasia, complex atypical hyperplasia. When I see the word atypical, that's the one that's got the P10 mutation as at risk for getting cancer. All right, mutations in which tumor suppressor gene is associated with endometrial hyperplasia. I just gave it away. Inactivating knockout of P10, because P10 is a brake. So to knock it out, now you get faster growth. All right, almost done here. What distinguishes hyperplasia from well-differentiated grade 1 endometrioid? Well, the glands are more atypical and they're back-to-back with no intervening stroma. So carcinoma has a lack of intervening stroma and, of course, a lot of nucleatypia as well. All right, now, what about a perimenopausal woman who has endometrial hyperplasia, P10 mutation, and an invasive uterine mass? That's going to be endometrioid carcinoma invading the wall. The deeper it goes, more likely it is to find a vessel and spread. Okay, what do you call it when you have a postmenopausal atrophic endometrium with a P52 mutation and an invasive mass? Okay, that mass is going to be serous, often papillary, adenocarcinoma. This is called type 2. Only 15%, but this is the one with P53 mutations, and it's very aggressive. Okay, what do you call it? You have a postmenopausal woman. She has a malignant endometrial carcinoma with a malignant stromal component. You call that a malignant mixed Mullerian tumor. Okay, so we call them triple MTs, mixed malignant Mullerian tumor, triple MT. All right, now what's the risk factor for ectopic tubal pregnancies? Scarring. Scarring from prior PID or scarring from endometriosis. Those are two big risk factors for ectopic tubal. All right, serous carcinomas of the fallopian tube are associated with what familial genetic mutation? Oh, the serous tumors of the fallopian tube are often seen in BRCA mutations. BRCA1, BRCA2, usually BRCA1 more. But BRCA mutations and fallopian tube carcinoma, they go hand in hand together. All right, next is the ovary. We'll do that next day.